Um, all right, we are now recording, and welcome everyone again to the Yale Survivorship Echo. I'm Jevin, the PA with the Yale Survivorship team. You know me from last time. And our team's here today. Tara Sampt, our medical director, Maura Harrigan, registered dietitian, Scott Capoza, our physical therapist, and Angela Kerala, our social worker as well. Thanks everyone for joining. If you can turn your video on, that'd be great. For everyone who sent back surveys, thank you for that. Continue to look for the emails for feedback for us. We got some great feedback already, and we're hoping to incorporate some of that today as well. We're going to be talking about survivorship nuts and bolts, and I wanted to jump right into it. We did introductions last time, and I think a lot of the people coming back today are here again from the first time. So we're not going to belabor any of that. So if I can go ahead and get started, I'll pull up our slideshow for nuts and bolts. And I want to make it clear too, forgive me, we're jumping in a little further here as I had it up already. We'll go back to the beginning. You know, I want to let everyone know if you have questions, feel free to chime in. Feel free to raise your hand and put something in the chat. We're going to keep an eye out for any questions. We're happy to stop and address them as we go along here, but we're also going to leave time for discussion. So I'm going to go ahead and get started with nuts and bolts. Again, today's brief agenda, similar. It'll be similar moving forward now, where a brief introduction like this, we're going to get into the presentation, leave some time for discussion, but also have a case presentation as well. I would encourage anyone, rather, if they have anybody they'd want to talk about, that would be great, excluding any protected health information, of course. And just some concluding statements at the end, and reminders for next time. So I wanted to start with an icebreaker, and just to get a few responses here from the group, and I'll stop the share here in a second. But I want to ask everyone, what is your current survivorship clinic model if you find yourself in a survivorship clinic, as a way to whet the appetites here for what we're to discuss. So what's your current survivorship model? Feel free to unmute and chime in or type into the chat.
Hey, Jevin, I can add my few comments. I do the treatment summary and then follow up with patients and make referrals out to the different providers based on what I assess and what patients report. And then I do some follow-up, but right now they're still being seen by Med-Onc for management of usually their AIs, and then just close follow-up as time goes on. We're hoping to build a real official survivorship program, so that's why you and I have communicated. So kind of exciting, and you know, it's what you realize, if for those of you who maybe aren't doing it, it's such a great time to meet with patients after their treatment. And then of course the referrals are phenomenal and downstream revenue is great. So it's all about quality of life and making it better for everybody. So it's an exciting part of the care.
Thanks, Mary. Yeah, and it sounds like things are getting built up there. Looks like Michelle raised her hand. Michelle Kirshner, go ahead, Michelle.
Yeah, so our program is interesting. We started with a combination of embedded post-treatment visits, you know, survivorship care planning visits, and then we created a consultative clinic for all the cancer types that they didn't, that we just didn't have buy-in or capacity within the teams. And you'll see, like, for example, a lot of times the breast teams, they really want to see their patients and do the, you know, post-treatment survivorship care. We had that also with our gynecologic cancers, but then there's many other cancers. And so the question is, how do you capture everything else? And so having a consultative clinic is really helpful. And what happened is that over time, people have just stopped doing the integrated visits, and we're now getting everybody into that one consultative clinic. So it was helpful in having, sometimes you have to just kind of do what's right for each cancer type and be flexible.
Totally agree. And yeah, I mean, that's the name of the game, is being flexible. And we know, as you'll hear from where we practice out of in different locations, we try to be flexible here. So thank you for that. And it's really interesting to hear everyone's feedback on what they're doing for survivorship. Does anyone else have any comments on what their survivorship model looks like? Christy Howlett, raise your hand. Go ahead, Christy.
Yeah, so we built ours out. Right now, we're just in the process of in seeing breast patients, since that's the largest group, and it tends to be easier to jump into. But right now, there's one nurse practitioner, myself. The oncologist refers the patient to the survivorship clinic. We see them about 4 to 6 weeks post active treatment, whatever that be it surgery, radiation, chemo, all three. And then at that point, it's a treatment summary, as well as just laying out the plan of what they can expect over the life of continuing into survivorship, with regards to seeing their oncologist as well. And then we start the long-term follow-up plan, is the alternating with the oncologist over the time they're receiving their medication. So they'll see me and follow up, and then the oncologist, and kind of going back and forth. And then what we're really looking at now is, how do we transition patients who are maybe 2 or 3 years into survivorship solely to the survivorship clinic from the oncologist, because they're so impacted. So the first place was taking some of the impaction off their plate with alternating visits, and then how can we follow them? That's a little bit more of a tricky struggle, because a lot of times the oncologists, they don't want to give up those patients. You know, it's nice to see people doing well in the long run.
Christy, thank you. And that, yeah, definitely a lot to consider there, advantages, disadvantages to one thing over another. Is there, I think we have time for one more person if someone wants to chime in about what they're doing.
Tessa raised her hand, Jevin. If
Oh,
you could
Tessa.
see that.
Yes, thank you. Go ahead, Tessa.
Hey there. I think ours is sort of a mishmash. So we do one-time consults, and that is either self-referred or from the oncologist. We also have long-term survivors, so they can be 3 years out or 1 year out for the colorectals. And so that's sort of like a centralized model. And then we also have a survivorship practitioner embedded in the liquid tumors. So that's actually how Roswell has done it, is just trying to meet the patients and the oncologist where they're ready.
I love that. Meeting them where they're at. That's so important. It's a key takeaway. Looks like Carrie Ann mentioned in the chat, we start survivorship care from initial diagnosis and utilize a collaborative care model. The Cancer Survivorship Services team includes a nurse practitioner, social workers, and psycho-oncologists. Patients are referred by oncology providers. That's so cool that a psycho-oncologist is part of the clinic there, Carrie Ann. Thanks for giving that feedback. Okay, so I appreciate everyone's feedback. And as you can see, everyone's doing something a little bit different. So let's jump into some of that with our topic today, the nuts and bolts of a survivorship clinic. And I think I did the same thing. Oh, there we go, right back to it here. So thanks for taking the time there. So let's get in. We're going to talk about some of the survivorship guidelines today, who would be eligible to attend a survivorship clinic, how referrals can be made, how we bill, sources of funding, and then we'll go through our intake forms. And you know, the caveat being here, this is from our perspective, but we're interested to hear what everyone else is doing as we started breaking the ice there a little bit. So as you know, there are the newer standards of the commission, from the Commission on Cancer, for survivorship care. And the new model takes away what was a requirement for survivorship care plans and makes it a recommendation. And now the focus is instead on services offered. And particular to our clinic with the multidisciplinary approach, we have a social worker, a registered dietitian, and physical therapist. So you can see those, I highlighted some of those here. But there are other services that can be provided, as noted here on the right as well. So it's great that there's this focus on services that can be offered to meet people where they're at coming into survivorship clinic, depending on your population. So who would be eligible? We kind of broached the subject of survivors, someone from the time of diagnosis throughout the remaining balance of his or her life. So for adult clinics, we're seeing people who are adult men and women of all cancer types. Usually they're coming to see us after they've completed active treatment, but I'm gonna give a little caveat to that too. People can be on maintenance or hormonal therapy. Sort of that caveat part of it here is people who are also on stable treatment with a stable metastatic disease, on long-term follow-up care or surveillance. And we also have a long-term follow-up clinic as part of our model for our breast program as well. And referrals to the survivorship clinic for us are generated in Epic. And the good thing is anybody can provide that. It can be any provider. And we even allow people to self-refer if they reach out to our clinic and ask for a survivorship visit, and we are able to review their history, get them in with us. And there are certainly barriers and challenges to getting buy-in for this, and I'd love to explore that a little bit more with everyone here, but things can be like generating the care plan, finding the resources, finding the people for it. And then also, this can be part of a standard for certain clinical trials. So for example, the lifestyle, exercise, and nutrition study done here at Yale, that was part of that protocol, was to have a survivorship visit at the end of that. And Dr. Sanft and Maura can talk definitely more on that. I did want to address this, and we got some great feedback as from one of the post-session surveys, and it was about resources, and I wanted to include this here. It's so important. As you've heard already, there's so many models of survivorship, integrated models, multidisciplinary models like us, for example. And I put a link in here to the ASCO website highlighting those models and the advantages and disadvantages. I think that's something we could explore in discussion too, maybe, whether it's embedded in the clinic where it's APP driven, or a multidisciplinary model here, for example, which can be helpful for managing complex needs. But it's so important to set a time for these survivorship-based discussions, things that are not addressed in routine follow-up, such as cancer recurrence, fatigue, weight management, some of these late effects that aren't always directly addressed in routine oncology follow-up, and even the survivorship care plan. So it's important to get buy-in and identify champions in your network, in your, your close by region, whether it's physical therapy or nutrition or social work or other specialties like psycho-oncology, for example, who might be interested in helping with this. And networks like this, like what we have here, are so important for that, building those relationships. And it's important to let our patients know, let our survivors know that these services exist, survivorship clinics exist. One of the most common comments we get is, I wish I knew about this sooner. So it's something that, we want to make sure we're getting the word out there and doing things to promote that, whether it's opportunities to talk with people or webinars or things like that. And then care coordination is so important. And again, communicating with other disciplines. Something I'll do at the end of visits is CC the entire care team on a note. So that way there can be this coordination between providers, but also having regular meetings sometimes with multiple disciplines, if you're not having the luxury of a multidisciplinary clinic, can be helpful too. And so I think it's so important to have these things in place. And certainly happy to discuss this more after. And for the survivorship visit, we do bill for our services. However, for a multidisciplinary clinic, our multidisciplinary clinic here, we bill for just the medical oncology component, whether they're seeing Tara, whether they're seeing myself. It's billed as a routine 25-minute follow-up for visits, a consultative visit with us. It's usually covered by most insurances with typical copays. And Scott, I'm going to turn it over to you.
Yeah, thanks, Jevin. So we do realize that to have multiple providers, but to only have it billed through the medical visit is very unique. We did start our clinic. Our clinic was started by philanthropic funds that were started outside of the hospital, and there was a donation that was made to the hospital with the premise of building this survivorship clinic that we're a part of now. And after several years, then our institution, Yale Cancer Center, took over from that. And we now have a fundraising event, a bike ride, every fall, closer to free. And we receive funds from that. And that helps to kind of offset the cost of the additional providers, namely, myself and Angela and Maura, because you're right, like, you wouldn't want to have something like this be cost prohibitive for the patient to get charged, 4 different copays to see the 4 different providers. So we know that, we are a little bit unique in that sense, and that we know that that funding can be, a big question. And so, yeah, we were definitely able to seek those, or able to get those funds outside of the hospital first, and then the hospital was able to take over funding our clinic from there.
Can I chime in a little bit about that, Scott, real quick? Just, one comment is survivorship is so good for cancer center marketing because it's such a positive part of what we do in cancer that, if there are fundraisers, it's not a bad idea to work closely with the heads of these things, because sort of in exchange for us, we're always being interviewed for promoting the Closer to Free ride. We take pictures and we're in their commercials, and then it's they get something which is able to advertise some of the positive parts of cancer care, and then in return some unspoken, we were continually funded. It's a very nice partnership. So curious on people's thoughts on this during the discussion.
Yeah, that's a very good point, Dr. Stamps. It's a very symbiotic relationship. And so when we started back in 2006, we were, that was actually before Smilow Cancer Hospital, the physical building, actually existed. So we were actually kind of sharing rooms with one of the med-onc clinics here at the hospital. And then when the Smilow Cancer Hospital building, the physical building, opened in 2009, we did have space on the first floor, and we thought that this would be great, that patients can come in and they may be going to other appointments, but they could see that survivorship is kind of the end goal, so to speak. There's kind of the light at the end of the tunnel in some ways. But what we realized, though, is that not everybody wants to come back to the center where they were treated. There's definitely some level of PTSD for some patients who don't want to return to that location. So, plus, for those of you who are familiar with New Haven, Connecticut, our traffic is not on the same level as New York and Boston, but it's definitely not easy to navigate one-way streets and pay for parking and that sort of thing. So we do actually rotate out to our community care centers. And so every Wednesday is a protected day for Survivorship Clinic, but we do go to different care centers throughout New Haven County. So for folks who are able to come to New Haven, to the main cancer hospital, that's great. But also to be able to reach more people, to reach further out beyond the immediate geographic area of New Haven, it's been great for us to be in our satellite clinics, which are based in Orange, North Haven, and in Guilford, in New Haven County.
I think I'll chime in here. I'm just doing a quick time check. We're at 12:20. So, briefly, pre-clinic, we do ask patients to fill out some information that helps us as a team prepare to see them. And they're listed here. We use the distress thermometer, the NCCN distress thermometer, the brief fatigue inventory. We do have a quality of life questionnaire. We're using the FACT general. And then after the visit, we redo the distress thermometer immediately after, and we also have a post-visit survey. We're happy to share any of these with you. We also use kind of an open-ended intake question about what are your top 2 concerns, and I think that's a validated survey called My Cause, and happy to share that as well. Before we see patients, Jevin does a really nice review and prepares the patient sort of from a multidisciplinary aspect, and we get together on the clinic day. So we got together this morning, we reviewed all the patients coming in, and it includes their diagnosis and treatment history, and then a review of their case as it relates to our specialties, as well as their intake form answers. There it is. So this is the My Cause. This is probably, to me, I think one of the most helpful tools we've ever used. And we've tried all different kinds of surveys. It asks the patient prior to coming in, what are your top 2 primary concerns? And you can see on the right-hand side, there is no check boxes, like it's just whatever is on the patient's mind. So you really get, I think, in the patient's own words, like what they're hoping to cover. And then part of the survey asks, how bothersome is this to you? It's a copy of our distress tool. Keep going, Jevin, just for the sake of time. Yeah, the brief fatigue inventory. We'll send all these out. Go ahead. Yeah, fact form. We also track supplement use, and we've published some papers on this recently on looking at supplement use in cancer survivorship. And then our post survey asks again about those top 2 concerns and how well you felt we addressed them, and then a few other satisfaction questions.
Thanks, Tara. Appreciate that. And yeah, so those are some of the forms that we go through. I'll attach those in the box website for everyone to have access to as well. And I wanted to mention here that part of my role, in particular, and Tara's role too, when she's seeing people here in clinic, is to really focus on that communication with other providers and finding services that our survivors need as well. So whether it's sexual health related concerns, whether it's cardio oncology, whether it's other rehab services, or having outpatient physical therapy started, these are all things, among others, that we will refer to routinely. And that's dependent upon a person's diagnosis, their treatment, and then where they're at, of course, right, with any physical limitations and so on. So we really try to hone in on individualizing that care and resources needed for them. And then part of it, I'm not going to belabor this point here, but this is the survivorship care plan. And I make sure that I'm going through for every person that we see to put one of these together. It's individualized with a person's diagnosis, treatment, and follow-up recommendations. And the nice thing for us, at least, is that we have this embedded in Epic. But there are a number of layouts for this through ASCO, through OncoLink. There was one through Journey Forward previously, but no longer exists. It takes, on average for me, especially with our biggest population being breast, probably about 15 to 30 minutes, depending, to complete. For some diagnoses, it can take a bit longer depending on a person's treatment course and so on. Happy to talk more about that after this too. So I wanted to wrap up this discussion and maybe get other people's thoughts and bring in some of that conversation again on what your ideal world for survivorship would look like. What would be the environment you would practice in? What would be the services you would include? And I want to stop the share there so we can see everyone again. I'm happy to ask you to unmute or put into the chat your thoughts on the ideal survivorship location and services you could provide. And I'll just mention, ideal meaning money is not an issue. You could have a 5-star hotel as part of your.
Can I throw out some ideas of my dream clinic? As a dietitian, I would love to have a kitchen setting to conduct classes, cooking classes, alongside a gym, a small gym for physical therapy. So, you know, having it in kind of a clinical setting in an exam room, to me, is not the ideal. And that's what we've been the space we were given. But it'd be much better to have it in a setting where you can actually teach the skills that you're talking about, and just making it more real life and applicable to their day. That's kind of my pitch.
I like it. We gotta figure out a way to get that going. Christy, I saw that your hand was raised. Go ahead.
I actually was going to say almost the exact same thing that Morris said. I think in the ideal setting, I would like it to still be in a location where it's kind of close to oncology, so they still feel connected on both sides, but maybe on a different level or a different floor of the location. But incorporating in a kitchen, I think, is an awesome idea so that patients can really learn how simple eating clean and whole foods can be. Because I think patients tend to make it out to be rocket science, like some of us do. Like nutrition is so hard, but then also I think just the exercise component of really having like a clinic or a gym focus where they can learn how, because we tell patients all the time, okay, you need to start exercising, but what does that actually mean? And finding what patients really like. So I think it's more than the clinical side of here's a form, how are you doing, but here's the tools. So that would be my ideal world. And I do agree with like not having an exam room per se, but maybe more of a lounge type setting where it feels a little bit more comfortable and you're sitting next to one another in like easy chairs and it's more collaborative and dialoguing.
That sounds great, and I love that. And those are all things that have been on our wish list for something too. And I wanted to give a shout out to Michelle Kirshner here too. She mentioned in the chat, survivorship services alongside all specialty support services, image center, exercise and rehab program, mental health services. I think that would be awesome to have that. Again, that very multidisciplinary sort of approach, and we all can support that for sure. Does anyone else have additional thoughts? Oh, Tara, great point too. Sexual health services, I like it. Something we see very commonly, especially in our breast cancer survivor population.
This is Angela. I, as the social worker, I would love to have my own private office, like with that kind of relaxing, serene setting, maybe a beautiful view of the mountains or a beach. Be able to facilitate like support groups, you know, in a setting that's relaxing, teach deep breathing, guided imagery, a setting where people can do yoga, you know. So I think that would also be, you know, on my wish list, but it goes with everything that everybody else is saying.
Thanks, Angela. Yeah, that's a great point too. And yeah, I think our survivors would find that so super relaxing and helpful to be in that environment. I want to shift gears a little bit here as we're up against the half-hour mark. We have a case study that we'd love to share with everyone, but I want to offer anybody else here, if there's an experience you've had in your own survivorship clinics or even with a cancer survivor that you'd want to share and discuss, be happy to listen. We would all be happy to listen and provide any thoughts, feedback, answer any questions there might be. I'll give it a moment here.
And I think it's helpful maybe, Jevin, for people who've never done an echo before, the case is really sort of a part of the discussion. And I know today we're talking about nuts and bolts, so how do you like bring up a case? Could be anything, honestly. But for those going forward, you know, fear of cancer recurrence, Jevin will kind of talk us through that at the end. But, you know, if you have somebody that you notice and you're like, oh yeah, that signals fear of cancer recurrence, like bring it and we can talk about it. It should be, we want it to be easy and interactive. You know, so going forward, each week we'll have a theme, a more specific theme, and you can think about if you have any patients that sort of jog your thoughts on those types of themes.
Yeah, so this week it can be a hodgepodge. Anybody you'd like to talk about, feel free to bring it up. I'll give another moment here. Okay, so I think we'll move on to what we have, and I'll share the screen again. Let me just find it here. I have it up. There we go. Okay, so today we are going to talk about Mr. C. And Mr. C, when we had seen him, he was a 70-year-old gentleman. He had a history of a head and neck cancer. He had a salivary duct carcinoma, involving the right temporal bone and right parotid gland, and was stage
Devin?
4. Yeah.
Can you zoom in a little bit?
Oh,
I'm
sure.
having a hard time seeing a lot of white space on the sides. Perfect.
Yeah. And I wonder if I can do the read mode, if that would help. Probably easier.
Yeah, that's good.
Okay. Let me just minimize this here. Okay, now I can see. So he, since he had come to us the first time, it was only 6 months after his diagnosis. And then the second time, he was actually 5 years out. And it was a good example of changing needs over time. And that's why we offer follow-up in our survivorship clinic. And so we didn't have any particular challenges, but the two primary concerns that he came in with the first clinic visit was loss of nerves in his face, dry eyes, and speech problems. And they put it on this scale of 0 to 6, 0 being the best, 6 being the worst possible. That was a 5 out of 6, and mental strain and anguish a 3 out of 6. And the second clinic visit, he mentioned limited taste sensation. And then after reaching 5 years after his diagnosis, he vacillated between relief and worry and struggled with his appearance as well, but he had developed a coping strategy for it, which I'm happy to talk a little bit more about in a moment. But some of what he had gone through for his treatment, he had a significant surgery, right intratemporal fossum parapharyngeal resection, a right modified radical neck dissection, and right radical parotidectomy. He had flap replacement as well, facial nerve graft. And he did receive adjuvant therapy. He had cisplatin over 8 weeks concurrent with proton beam radiation. He had some side effects associated with that. And then, unfortunately, more recently, he was diagnosed with a new prostate cancer as well. And we actually haven't seen him since this new diagnosis. He had a slowly rising PSA. They did a biopsy, saw he was Gleason grade 6 out of 10. And right now he's having just active surveillance to watch his newly diagnosed prostate cancer. So, let me see here. I'm going to go back to the regular mode to get down here. Wasn't letting me move ahead, forgive me. So some other pertinent information. He lives with his wife. He's a retired psychologist. He has 1 alcoholic beverage a week. He is pretty active, and he had lost some weight after his treatment, but he then gained it back. He doesn't get 5 servings of fruits and vegetables a day, but he doesn't use any additional supplements or anything like that. It lists his past medical history and family history here. And he continues to attend the head and neck cancer support group. Before our team jumps into thoughts on his case, I wanted to pose some questions to the group with some of that in mind. I'll leave this up on the screen here for a moment, but we can start with just the first one. What are some of the late effects from treatment you might consider for this survivor? And we'd love to hear some of people's thoughts about that. And again, feel free to type in the chat or unmute. I'm going to stop the share so I can see all of you again. I'm happy to go back to it though.
So in summary, Jevin, he's a 70-year-old with head and neck cancer, right? Who's had major resection and chemo radiation more than 5 years ago.
More than 5 years ago, and the chemo he had was cisplatin, and he's been newly diagnosed with prostate cancer. So what late effects might you expect from someone who's gone through the treatment he's had? The resection, cisplatin, and radiation. All right, I see a comment here from Tessa Flores. Hearing loss, loss of opening angle of his mouth, and dental caries. Definitely all very valid concerns. We advise a lot of our head and neck survivors to continue with dental care. Sindal mentioned thyroid dysfunction. Michelle mentioned dysphagia. I'm seeing here, Tara, secondary cancer risk, thyroid dysfunction, renal function, carotid artery stenosis, dry mouth. That's a great one, Jill. Thanks for that. I see Athena and Stacy chiming in. Cancer-related fatigue, neuropathy, balance issues, range of motion of neck, and fibrotic changes as well. These are all very valid concerns that he would have, right? And some things that we all address, I'm sure. Lymphedema, another great one. Thanks, Christy. You can see head and neck cancer survivors, they really benefit from these multiple disciplines. Does anyone want to provide some feedback on ways they might address some of these concerns? And it looks like Sindal was asking too, does anybody screen for carotid artery stenosis? Anyone want to chime in on that if that's something that you've done in your practice?
Since I did that, we listen to the carotid to see if they have bruits, and if they have bruits, unfortunately, Roswell no longer does carotid artery Dopplers, so I contact the PMD and ask them for a follow-up.
Great, thanks, Tessa. Appreciate it.
I sit on the NCCN AYA guidelines, and this came up actually at our annual review of the guidelines. Someone had suggested maybe adding in carotid artery screening for the population of kids who have had radiation in this area. It didn't make it into the guidelines, but Tessa, I agree with you. Listening for bruits is probably the best place to start. And then
the hard part is primary care doctors, they were recommended years ago to not listen for carotid bruits unless they're symptomatic. So, usually by the time they're symptomatic, they already will need some sort of intervention. And I mean, that's hard. If we're not listening to it and they're not listening to it, when they become symptomatic, it means intervention.
Yes. I'd love to hear from the primary care doctors on this call. Like, how are you handling carotid stenosis screening?
Yeah, I do listen. I listen to pretty much all my patients. I mean, certainly those that have hypercholesterolemia and a prior history of radiation, those folks I might just send to carotid ultrasound, and even in the absence of a bruit, because sometimes a bruit is more likely turbulent flow and not actually significant plaque or narrowing. But for folks, and we're fighting with people every day about going on a statin, right? So if you document plaque on a carotid ultrasound, then you have a little bit in your wheelhouse to be able to sort of argue about the benefits of statin therapy for them as well. So that's sort of how I handle that conversation.
Thank you.
Yeah, it's a great point, and definitely some other comments here coming in too. Difficult to get payment on carotid screening without formal recommendations, and so one of the things is advocating for preventive care, seeing primary care, following up on lipids. Definitely good to consider too, as we've heard from everyone here. So that's a great point. Were there any other late effects that people might want to chime in about management on, or moving on to the next question? Or
that is that a lot of those folks also end up getting some sort of ultrasound to evaluate their thyroid, and if you order that as a neck rather than as a thyroid ultrasound, then you'll get some commentary made about the carotid at the same time, just as a way to be able to sort of capture another data point when you're evaluating them.
it was really helpful. Yeah.
I think we should move on to the next points, or we should have our team sort of review this case if you were planning on having them give some thoughts.
Yeah, so I mean, some of the other questions, I guess I'll lay them out here. We talked about some of the management strategies, particularly with carotid stenosis. What might be some other services you would benefit from, or psychosocial considerations? I think we got some of that in the chat as well. And then recently with his diagnosis of prostate cancer, how might he feel having had now a second cancer diagnosis after living beyond what he thought he would after his first? And how might you counsel him with that in mind if someone, say, has fear of cancer recurrence or concerns having had a second cancer now? I'll stop and see if anyone has additional thoughts, and then we can jump in and say what he's been.
Yeah, I mean, there were a lot of second late effects on xerostomia and dental caries, and I wonder if Maura, if you wanted to comment a little bit. You saw this patient, and just comment a little bit about those late effects and management from your perspective.
Yes, so with head and neck, they have a tough go and they really need a lot of help eating well. And so with this gentleman, what was beneficial that his wife accompanied him, and she was responsible for all the food shopping and food preparation. So she's the one with all the questions. So it was helpful to have her there. And the patient was having great difficulty still with dry mouth, difficulty chewing, therefore difficulty swallowing, and had a very limited range of foods that he was willing to eat. Granted, his weight was stable, so that was good. Oftentimes in this population, we see a large weight loss. And so what and he also had trouble eating in front of other people because of the, the surgery. And that was very stressful for him. So when they would go eat out, he was very limited in what he felt he could eat without embarrassing himself. So I spent a lot of time with them with, I have a whole host of nutrient-dense recipes that are easy to prepare, that are of a soft texture, where, because that was really what we needed to do for this gentleman, was expand the nutrient density, increase the nutrient density of the foods that he was taking in, and giving him safe textures that he could chew and swallow safely, but also manage it in front of other people. And they found that very helpful.
And kind of to dovetail off of that, he, from a physical therapy perspective, we did talk about range of motion activities, but because of the difficulties with chewing and swallowing and that sort of thing, that was one of the referrals that we actually made, was to speech therapy, to do a comprehensive swallow evaluation, to again kind of help complement the dietary recommendations, and to make sure that that he was able to swallow correctly, and if he needed any concerns, because he did come to us concerns with his speech as well. And so he hadn't been seeing a speech therapist to that point. And so, in addition, for us to be able to do our PT interventions, like we were able to set up that referral to speech therapy as well. And when he came back to us for that follow-up visit, he said that it was very, very helpful.
Scott, based on, do you want to also comment a little bit about the range of motion issues? I think someone brought that up too, and we definitely appreciate your help when we see these types of patients.
Yeah, I think especially again with the head and neck population, I talk about the importance of a home exercise program and daily stretching, and again trying to figure out how to make that integrated into their daily routine. And so a lot of times I will tell patients that, I want them to try to do it as part of their morning routine, right? They get up, they take a shower, they're in front of the mirror already, they're going to brush their teeth. I want them to do their stretches because they also are right in front of the mirror. So they get that feedback when they have to do their chin tucks, and they need to do their rotations and their side bending and all of that. And if they're able to integrate that into that morning routine, then they don't have to worry about, well, did I stretch yet today? Did I not stretch yet today? Like if it just becomes part of, getting ready for the day, then you are capturing them to be able to do that stretching right then and there. And then if they're able to add that in for their evening routine, same thing. They put their pajamas on, they wash their face, they brush their teeth, they're in front of the mirror, stretch, right? And then that way it doesn't seem that it's overwhelming, because that's the last thing we want to do, is to give our patients more things to do and they become overwhelmed. And if they're overwhelmed, they're not going to do them. So if it's easy to integrate it into these morning and evening routines, then they're hopefully more likely to follow up with that.
I think that some of our patients are really surprised when they find that their range of motion gets worse over time, but yet they hadn't been doing their exercises. So it's not something that, you take care of right after surgery and then you're in the clear. It's a constant threat long-term.
Yeah, and that's, and Dr. Sant, that's exactly how I explain it to patients is you brush your teeth every day, right? To maintain the health and integrity of your teeth. So you have to stretch every day to maintain the health and integrity of those muscles and that skin and that connective tissue, especially post-surgically and post-radiation. So I try to draw that parallel.
Yeah. I think the last thing to mention is the xerostomia. We've been fortunate to have a few acupuncturists in the area who understand how to do acupuncture for xerostomia, and they're not in our system, but we refer patients to them in the state, and we've gotten great feedback on that. And I don't know if anyone else on the call has other things that they use for xerostomia, but acupuncture definitely has been a helpful intervention.
So I guess, should I talk about the psychosocial aspect? So I have to say this particular patient, he was like the star pupil. So he's the kind of patient that whatever you recommended, he would do. So he was really good about that. From a psychosocial perspective, the first visit that I had with him, he actually overall was doing pretty well emotionally. With him having a psychology background, he already was doing a lot of those things intuitively that he knew that would be helpful to him on an emotional level. He did have a psychologist who he was working with when he was initially diagnosed. And he actually got care at Smilo as well as another facility. And so he was hooked in with the psychologist from the other facility. But when he came to us, one of the things that he talked about was this mental anguish. And what the mental anguish was about was his particular type of cancer is very, very rare. In fact, so rare, only a handful of people have this diagnosis. And because of that, there aren't survival rates that he could be told. And so that was the one thing that he really struggled with. He had no idea how much time he had left. How much time he had on this earth. And so one of the things that he and I spoke about was, again, that the concept of bringing purpose and meaning to his life and what that would look like for him. One of the times that I did meet with him, he said something so impactful for me that I actually use it with other patients. He basically said to me that every single day that he gets up, he sets one small goal for himself. And if he achieves that goal, by the end of the day, if something were to happen, and heaven forbid he passed away in the middle of the night, he would know that he ended his time here on this earth accomplishing all that he had set forth to do. And I thought that that was absolutely beautiful, because he really did not have any idea of knowing how much time he truly had left. And unfortunately, several other people who had this diagnosis had passed, and he was aware of it. The other thing that he took full advantage of is our integrative services. So he got involved with our yoga, he got involved with our meditation, he did journal writing, poetry. So he really took advantage to all that we have to offer and really benefited from that.
Thanks, Angela. Appreciate that. And thanks, Maura, Scott, and Tara for also chiming in about the visit with him too. And, I had just to quickly dovetail off of what Angela was saying and some of the coping strategies he was implementing. My visit with him was spent going through his care plan in large part, but one thing he shared with me that I found interesting, he developed a coping strategy, and kind of going back to what Maura was talking about, with how others might view him, such as with eating in public and how he struggled with that. And he worked as a psychologist, and I think that's a important point here, but he thought about how others perceive things and what's normal on a day-to-day basis. And for them, for anybody seeing something abnormal, it could be something that's a bit more, again, out of the ordinary and sometimes shocking to someone who hasn't experienced this before. So he tried keeping that in mind and really changing his perspective on how others viewed him. So like say if you know, a young child or someone like that, you know, said something, he wouldn't take it personally, but really try to keep that in perspective. And I thought that was really powerful to hear that he was able to do that for his own well-being. So before we move ahead, does anyone else have additional thoughts on this case, or maybe a case like that you've experienced in your own clinics?
Maybe we can forecast sort of what the next few weeks will look like. And so this group can think about patients that might fit under the next themes that we have coming up.
Yes, that would be perfect, Tara. Thanks. And let me go ahead and I want to share this one image, which I thought was pretty cool. So that hair might look a bit familiar from someone here in the discussion with us today. Maura, she was in the Closer to Free ride. Maura, do you want to share quickly on what this was?
Yes, I rode in Close to Free, and those ribbons, they're on those ribbons in the name of every participant in the Lean study to date. I rode in their honor. Many of these women also went through the survivorship clinic. When I finished the race, I sent each woman their ribbon with a note. And since then, these ribbons live on. And these women wear their ribbons in their own activities. They send me pictures when they finish their 5K with their ribbon pinned to their hip. And so it's just a beautiful, you know, symbolic, but also just that connection of that we carry on and keep moving forward in wellness, which is one of our messages in survivorship.
Maura, that was so cool to see, and what a great way to really personalize that experience with them. So thanks for sharing that too. And for what's coming up next, our next session is going to be next Wednesday, May 18th. Same time, same place here on our Zoom Echo from 12 to 1 p.m. Eastern Standard Time. It's going to be on cancer-related fatigue. And again, feel free to bring your own case. Anybody you might think would be interested with regards to cancer-related fatigue. But we're open to anything ultimately. But that'll be the topic of discussion for the day. Make sure also you complete the post-session survey for today if you have a chance to. And I'm going to go ahead and stop the share here and mention that our next subsequent sessions after cancer-related fatigue next week will be fear of cancer recurrence, energy balance, talking about weight management, nutrition, and physical activity. And then we're going to round out the end of it with cancer and cognition. And we have a guest speaker for that, Franklin Brown, from our neuropsychology clinic here at Yale, who's going to be talking a bit about that, fielding any questions or thoughts you might have on it. I know we have about 4 minutes left. I'm happy to give the time back to everyone today. And thank you all for joining us and taking the time out of your busy days. And until next time, it's good seeing all of you. And thanks again. Hope to see you in the future. Bye, everybody.
Thanks, Jevin. Great job.
Thank you.